Welcome, everybody, to our discussion today on cardiovascular disease. My name is Dr. Susan Blum. I am here at Blum Center for Health at our offices. I'm so happy to welcome all of you for our discussion today. And with me today is Dr. Andrews. Dr. Andrews, you want to introduce yourself?
Yeah, and hi, I'm Dr. Jamie Andrews. I'm delighted to be here. Always excited to talk about cardiovascular health. I'm a clinician here at the Blum Center and treating patients.
Great. And so Dr. Andrews and I, well, we both have a passion for heart disease and assessing risk for heart disease. And we had this idea to talk to everyone about it today, or to offer this sort of conversation so that we could really kind of sort of bring you into the way we think about this, right? Because heart disease is so prevalent. It's one of the things that we look at in every single patient. So it doesn't matter whether or not you're coming in to see us for autoimmune disease or for your thyroid or for your, inflammatory or irritable bowel. We're always doing a good look under the hood at all preventable and risk factors and screenings for important aspects of your health that we can actually help improve, right? And help you to, preventive medicine is one of our passions. In addition to, of course, we're doing functional medicine here, but preventive medicine and lifestyle medicine is integral to all of it. And at the end of the day, we're looking at you as a whole person. And so looking at your risk for heart disease and helping guide you on how to know what your cholesterol level should be, what your target should be, how to know sort of what the goals would be for you as a personalized individual are really important. And so we're going to offer you a glimpse into the way we think today. We're going to offer you a glimpse into the way we approach this and the tests we do. And hopefully you'll walk away today with really good ideas about what you want to ask your doctor for, what tests you want to ask them for, and how you might think about the results of those tests. So yeah, so as we get started, I think it's really important to sort of help everyone understand, help all of you understand, why is heart disease such an important issue, right? And Dr. Andrews, you want to jump into that one?
Yeah, I mean, 44% of American women currently today have heart disease, which is an almost incomprehensible number of us. And heart disease is killing 40% more Americans every year than all cancers combined. Sadly, the fastest growing population affected by heart disease is young people. It's 25 to 44-year-olds. And also, sadly, I think for a long time, the heart disease was not a long time, but for several years, heart disease was on the decline in America. But since 2017, cardiovascular disease is again on the rise. And I think this is multifactorial. We could get into it, but
Well, we are
the
going to get
point of
into
it
it.
is, yeah, the
Because
point of
all
it
the
is that
risks for heart disease are things we're going to talk about today. And these are all things that some of these are really on the rise, right? So, yeah.
so each person that is listening or thinking about this really has an opportunity now to think in what is my risk for heart disease? How high risk am I, and what kind of assessment do I need to know
Yeah.
that?
Yes. And, one of the things, I mean, we happen, one of the big populations of people that come into our office too are women going through menopause or midlife, women in midlife. And one of my favorite statistics is that heart disease is the number one killer of women after menopause. I mean, that's crazy, right? And we're so worried about our breast cancer risk, and we're worried about, ovarian, but like all our hormone related issues. And really, we need to be really aware of and on top of our risk for heart disease and whether or not we need to be minding the store, right, on that one, right? And
Exactly.
so
Yep.
good. So that sort of frames it. And this is the issue. This is why for us it's such a big issue. And the other thing that so makes it such a natural issue for us to be passionate about is because, lifestyle, right, weighs in so heavily, and we do so much lifestyle medicine here, right? And we're so good at it, functional integrative
Absolutely.
medicine. We have a lot of tools and things that we've been using for years and years to help people reduce, improve their lifestyle habits. So we'll come to that in a little bit. But before we do, how about maybe we should talk about we throw the word heart disease around all the time, right? So like we're saying, oh, heart disease risk. let's do slow down for a sec and do some good sort of definitions for everybody. So when we're talking about heart disease, what are we talking about? What do we mean?
So for the purposes of today's discussion, when we say heart disease, I'm really thinking about coronary artery disease. So atherosclerotic diseased arteries of the heart. When people say heart disease, that certainly includes heart failure, cardiomyopathies, arrhythmias, valvular disease, heart failure, many autoimmune heart, like many other entities. But for this discussion, what we're really talking about is atherosclerotic arterial disease.
Right. And I know that some people sent in questions in advance, and there were a few questions about things like tachycardia. And so at the end of the talk, I expect we'll have time to sort of
Touch on
circle
that.
back to that. Yeah. And
Yep.
so
Sure.
and circle back to those things. But I think that when we think about the things that are the number one killer, right, of women, or the number one killer of all people, or the
Yeah,
high
it
one
is.
of the
I mean,
biggest, yes, I
yeah.
know, is that coronary artery disease, right, which you just explained, when there's a blockage in the vessels, that's what causes heart attacks and kills people, right? And so these are the, and there are other, but really, and these are your cholesterol, which we're going to talk a lot about. These are ways we could help reduce your risk, right, of that happening. And so that's why we focus a lot on cholesterol, and the blocking of the arteries, because that's the most common way that heart disease kills people, right?
Yeah, and it's worth saying, like, not for nothing, for the majority of people, their first indication that they might have heart disease is a major adverse cardiovascular event, a MACE event. So, like, most,
And so what is that? Tell everyone what a
well,
MACE
if we're
is.
not really paying attention,
So
then
let's slow that down. A major adverse cardiac event.
event.
And so
Yeah.
what are those things?
So if you have a heart attack, for example, if you have, I mean, there are multiple types of heart attack, but like most people, that's really the number one.
Right.
I think that stroke is also in that category and might count as MACE as well.
Right, or ending up in the emergency room because you have chest pain and it's a valve issue, like something that brings you to the healthcare system because there's something wrong with your heart, right?
Yep, yep.
Yeah.
Now, yeah, I mean, there's a lot of chest pain that's not heart disease, but like, yes, the
Well, I mean, once
majority
it's
of our,
demonstrated that whatever brought you in is because there are other things that can cause that are heart related, right? Which you went through already,
yes.
that can bring people in. But really, we want to prevent heart attacks here, right? And the majority of heart attacks are because what is a heart attack, right? A heart attack is when there's death of the muscle in the heart.
Yeah,
Something
right.
caused that heart muscle to die, and then the pumping function of the heart doesn't work anymore.
Yeah, I mean, if you're unlucky, yeah, you end up with heart failure as a result of that ischemia or that muscle that's no longer getting blood flow. And so, yeah, I think of sometimes I describe it to patients like it's like a zit in your artery. So a lot of people can go along with these like little blockages, and then they get a little zit where that those foam cells and those macrophages are in that arterial lining, and when they kind of pop, then the artery all of a sudden that was like slowly getting blocked. Now it's just I guess people can't see me in essence. Well, you're just, yeah, the artery's just gone. You don't get any blood flow for that moment.
Right. So there's something that happens, that there's a choking off of the blood flow to the heart muscle. And if that goes on for long enough, and then you'll feel chest pain, right? So the first sign that you might have something choking off your blood vessel is you'll feel pain. And now I will tell you, having had my mother in my house when she had her heart attack, she did not have chest pain. Women have very atypical kind of signs of a heart attack. My mother actually had pain in her back. And she was just like, oh, my back hurts, my back hurts. And she was all sweaty and clammy, not down her left arm, not crushing chest pain. Men tend to have that constellation of symptoms. It's an interesting thing, right? So any weird, kind of pain in your back or in your chest, or any weird feeling, you should check it out. But the first sign that your blood vessel might be blocked a little bit could be this pain. And unless that blood vessel gets opened, and that's where you rush to the hospital and get a stent put in to get the blood flow opening so that the blood flow goes, if you don't get that stent in there in time, then the heart muscle can die. And then you end up in a situation where if your heart's a pump, and pieces of the heart muscle aren't working, the pump doesn't work as well. And that's another whole pile of symptoms we can get to later if we have time. But for now, I kind of want to bring us back because so this is what we don't want, right? So we ended up down this little rabbit hole talking about, yeah, what an adverse event is when the blood vessels get clogged and you end up with needing a stent or you end up with a heart attack. And so I think that to know if you're at risk for that, our goal today is to really help you understand if you are a high risk person, right? Because it's kind of a personal diagnosis that we make with each of our patients. It's like a kind of diagnosis. Are you a high risk person for having blocking one of these arteries? Or are you a low risk person? And there are all sorts of factors that weigh in. And today we are going to take you through our whole checklist that we do with every person that walks in our door to determine if you are a high risk person or a low risk person.
Mhm.
And at the end, we'll talk about like what we do with a high risk person and what we do with a low risk person. But first, let's go through, Dr. Andrews, how about if we go through first, what does it mean to have a high risk for heart disease? Like, what are the factors that weigh in that somebody should be thinking about that might
Yeah.
place them at high risk?
So, I mean, I had a patient last week, we were going through this. So there are some non-modifiable risk factors, and then there are things you can do things about, which we call modifiable. So, for example, your age is going to be a big risk for heart disease. There's nothing that we're going to do about that, although we can have a biological age discussion later. But essentially, your age is a risk we're not going to touch. Your family history. So, did either of your parents have a stent? Did they have atherosclerotic heart disease? Did they have a major adverse cardiovascular event? And we don't usually count grandparents in these risk scores. So sometimes we'll use like risk stratification, like, Framingham is an old one, but there are others risk stratification scores for cardiovascular event. The other major
Wait,
ones. So
slow down. I want to be clear about what you just said. So family history. Somebody has a positive family history that increases their risk for heart disease if what?
if either parent had a
Either
stent
parent,
or atherosclerotic heart disease or a major adverse cardiovascular event.
when they were under in their
60.
50s or 60s, right?
Right. Yes. Thank you. Yes.
Right.
Right.
Yeah.
Good.
Because if my mother had a heart attack when she was 80. So
Right. Right.
that
Right.
does
Right.
not count for me to put me at a higher risk for heart
For
disease.
the family heart. Right. Thank you. Mhm.
Okay, I just wanted to clear that. But if you have a parent that had something that everyone knew about, not just if they had high cholesterol, they had to have had, something happened. They either needed a stent or they had a heart attack or they knew that they were on angina medicine, they had angina. You knew that there was something like that and they were in their 50s or 60s, then you get a check in one of your boxes.
Right.
Okay, go ahead.
If you smoke, that puts you at risk. Mostly the data is around tobacco. We don't have a lot of data yet around sort of like marijuana smoke and like
There
other.
was a recent study that just came out on that.
Please enlighten me.
No, I actually, I think it's an important thing because the study that just came out like 2 weeks ago was about THC. And it doesn't matter how you take it, whether it's edible or whether it's edible or whether you smoke it, separate from the smoking aspect, that THC causes endothelial dysfunction, which is the blood vessels being like a little inflamed, and they then are an increased risk for making plaque. And so there's increased risk for heart disease in people who regularly consume THC. And I had this conversation, it just came out, and one of my patients last week for sleep, she has terrible pain. I'm trying to remember what her pain syndrome was, but oh no, she was trying to get off Ambien. So somebody gave her gummies that were CBD plus THC, and she started taking those she was taking them for a long time for sleep. Or she was planning on taking them anyway. It prompted this whole discussion. And I said, stick with the CBD by itself. Right. So it caused
Yeah.
me to change my thoughts about that because of this. It was in JAMA, the Journal of American Medical Association. I think it was the Journal of American Heart Association that was picked up by JAMA. I mean, it was a really sort of breaking news study because it was in the conventional heart disease journal. So I think it was the first time that they noted that THC could be not a good thing to be doing. Anyway, back to you. Sorry
Thank
to
you. No,
interrupt.
thanks for sharing that because I
Yeah.
think that's But,
Yeah.
when I talk to my patients as well, like that's what a lot of them are using, like for the same reasons, Susan, like sleep or pain, or for many
Well,
of them, very
CBD
good
we
reason.
use all the time, and that's fine.
Yeah,
That's
but the
not
THC.
CBD, but some people are using a little bit of THC in there.
Yep.
Look, at those doses, I can't tell you that the study could discern
Right.
dosing, and but t people that regularly consumed
THC
THC
had
or
a higher
edible, edibles, and it
was
was
linked.
and they figured out it was the THC itself. That
Mm,
was the issue. Yeah.
okay.
It was edibles or smoking or vaping or whatever people do, with it. Yeah. So anyway, these are things that, this is one of my favorite sayings is here we are doing this grand experiment on the human race with all these things we've done to ourselves over the past 20 years. And we don't find out till later what it's actually doing. And so, I mean, I think this is just a good example of that.
Yep. Yep. So the other, obesity and metabolic health is a huge risk factor.
What do you mean by metabolic health?
Yeah, so we look at a lot of factors, but essentially, how's your energy balance? Like, if you're overnourished, or if you're, thinking about elevated fasting insulin, elevated A1Cs, insulin resistance,
Right.
those factors are going to lead to,
Because we throw around the term metabolic syndrome, metabolic all the time. And I think
yeah,
listening or the average layperson doesn't necessarily know what we're referring to, but I know we are referring to insulin resistance, right?
correct,
Like the whole blood sugar system issues, which are over here,
correct.
right? So there's hypertension, there's all the blood sugar issues, which we measure, which we'll talk more about, at least also our way of really making sure, checking in on people, right? And assessing that.
Metabolic health, yeah.
Sorry, I know I keep interrupting you, but it's about.
No, it's great. Well, so for hypertension, yeah, that's another one. So we know now that blood pressure should be less than 130 systolic over less than 80, and that's thank you to the Sprint trial
It's
for
tightened up a little bit,
that.
right?
Yep, it's
Our
tightened
goals are less
up.
than they used to be. Yeah.
Yeah, and then the other major one, of course, is cholesterol. So ApoB, LDL levels. I, we've talked a lot
What about an LPA?
LP. Yeah, God, right. So types of cholesterol, atherogenicity of your type of cholesterol. We can get into some of the details there, but thinking about, I'll say cholesterol for now.
Right. And so we're going to talk a lot about cholesterol as we go through today, especially towards the end when we put it all together, and we'll help give you some guidance about your cholesterol. I think for here, though, I think we both agree, Dr. Andrews and I, that cholesterol is something to modify, right? And so by the end of today, I'm hoping you'll have a sense of what the goals should be for your cholesterol levels, depending on your risk assessment. But I do want to point out there's the other one called LPA, or lipoprotein little a. And that is a kind of a lipid measurement that we do, that when that is elevated, that is very genetically determined. So you could go on a statin, you could do all sorts of like cholesterol lowering medication, but it doesn't move that needle much. And so there are people with a very high LPA, and those people, that's a check. Just like your family history, I said check puts you into that you can't change. The LPA, if that's really elevated for you, that's check. That puts you into a high risk for heart disease, something you actually can't change. Hypertension, cholesterol, obesity, smoking, and even your cholesterol levels, those are things that we can work on, right? And help improve. There are things that you can't change. And family history is one, and the LPA is the other one.
I agree with everything you've said, except for that this LP little a, the PCSK9 inhibitors have moved the needle on that.
Okay.
But statins actually raise your LP little a. In fact, it's negligibly, but like
A little bit. Yeah,
they
yeah.
do. But like
Yeah.
the PCSK9
There is a very
inhibitors,
advanced kind of a treatment now that can lower that little LP little a, but it still means you're genetically at a high risk. It doesn't change your
correct.
risk. It doesn't move you out of the risk category if you lower it, does it?
Yeah, it does.
Okay.
Changed outcomes. Yeah,
Oh, okay, good. So good. So there is a treatment. Is that an injectable, by the way?
it is. Yeah.
It's an injection, yeah. We don't have great treatments for LP little a, but you're right, there is this new one that can be done. So that moves into the modifiable category then. But that's an important one to keep in mind too. But these are things we regularly test, right? We're checking everyone's ApoB.
Right.
We're checking their LP little a. Yeah.
Yeah.
So what else? What else puts people at risk?
Well, there's some like secondary things to mention. So dental disease, I mean, when I
Yeah.
say secondary, I just mean because it's harder to measure like the quantifiable impact, but we know that periodontal disease is a strong risk factor for atherosclerosis,
Yep.
not to mention, brain health, other factors. But that's really important. And we could sometimes get a signal for that on like looking at myeloperoxidase levels and some of the labs that we do.
Yeah, you mean for oxidative stress or like
Yeah,
the
yeah,
oxygen.
sometimes
Yeah.
we can get clues for that.
Yeah. The dental disease though is really interesting. I mean, that's where your dentist, we would tell people listening to make sure that when you go to your dentist that they are checking your pockets for it's periodontal disease, right? And it's an alteration in your oral microbiome. And so just like the gut microbiome is connected to a lot of things, and actually the oral microbiome is connected to rheumatoid arthritis, and that's a well connected, that's a well studied kind of mechanism. It appears it's also connected to heart disease. So it's the periodontal and the oral biome. So
In addition,
the
actually,
dentist.
that's probably the major one, but also if you have undetected apical caries, which happens more in diabetics and certain populations, those like undetected infections can also
Oh, yes,
go.
undetected infections. And so sometimes you need a more advanced kind of X-ray for that, right?
Yeah, the cone beam
Apical, those cone
CT
beam.
kind of
So
imaging.
sometimes you need a cone beam X-ray for that. So make sure your dentist is doing a very, very thorough look for hidden infections as well as periodontal disease. Yeah.
Yeah.
So what else? What else, Chris?
Well, genetics, which we'll get into, I'll just say that. But
Yep.
autoimmune disease puts you at risk for periodontal disease, which I mean, there's all these links that
Right.
are sort of multifactorial links. And estrogen, I love that you mentioned the menopause issue. So hormone levels certainly affect cardiovascular risk. There are many trials showing that. So
And
yeah,
what about heavy metals? Because we've talked about that a bunch
please,
here.
you should say something about this. Go ahead, Dr.
No,
Blum.
no. Well, I think it's really interesting that there's been an association. There's not a causation that's been proven, but there's an association between heavy metals like lead, especially. And I'm not sure which other metals. Do you know which other metals? I'm not sure it's mercury. I think it's mostly lead because I know that the chelation studies that are underway is mostly to chelate out and they follow lead levels. But
Interesting.
yeah, but there's probably other metals in there too. I'm not sure of the list of metals. It could be like cadmium or something.
Thallium, cadmium, whatever.
Yeah. So there's definitely a couple of heavy metals that are associated with heart disease. And there's some really good this is there's active studies right now happening looking at, and there was one preliminary study that was done which showed that by chelating out the metals, by doing intravenous chelation, you could lower the metals and help lower the risk, but it was done in a very small group. I think it was just diabetics. And so they're now expanded the study to the next grouping. But there is an association between exposure to heavy metals or levels of heavy metals and heart disease. And the next level now is to really look at the data for chelating and bringing the metals out to lower the risk. So this is a very exciting emerging area in cardiovascular health and treatment. And I
Yeah.
hope that this also underscores this, as Dr. Andrews and I are talking about this, we really practice evidence-based medicine here, right? So, I mean, Dr. Andrews has been practicing internal medicine for years and years, right? And you made the crossover to the other side, right, 4 years ago in functional medicine. But years and years, I mean, I'm doing this too, but we look at the studies and we really strive to follow the evidence and offer treatments that are supported by the studies and the literature. So I just wanted to add that. And so the heavy metals and chelation for heart disease is a place where this is my favorite cardiologist who I send everyone to. You know, he and I just had a great conversation about this, and he knows about this, and so it's interesting, right? So we in functional medicine we're sort of been in the forefront of doing these things, but I think a lot of the studies are really finally proving us right and catching up to us, right? That's how I like to think about it. Okay, so we digressed a little bit, so let's bring it on back. So we mentioned cholesterol, right? And you mentioned this thing called ApoB. So how about if we just talk about cholesterol and
Yeah.
talk about the different kinds of cholesterol? I think this is really confusing to a lot of people. You know,
Yeah.
how is it measured? There are different ways. What are particles? What's ApoB? I'm handing that off to you.
Well, I think that most people, if you go to your primary care doctor, at least historically and probably today too, will get a lipid panel done. If you ask about cholesterol, it will be a lipid panel, and that will include your LDL, your HDL, your triglycerides, and your total cholesterol. The LDL has certainly been linked to atherosclerotic heart disease. However, we have evolved a little bit since just looking at LDL. So we maybe, I don't know, 2010, people started realizing that LDL particle number, or LDLP, was more accurate at predicting cardiovascular risk than LDL-C, or LDL, like your total LDL cholesterol. So I think about it like if the artery is like a highway and the LDL-C is the amount of tons of, I don't know, tons of sand moving down the highway, the LDLP is the number of trucks. So it's like the number of like carriers that are moving this sand down the highway. So it turns out that the number of trucks might be more important than the actual quantity of sand. Okay. So then we started doing LDLPs. And then what we find out later is that, well, if you look at just the trucks, you're missing the motorcycles and the buses, and there's these other atherogenic particles. So your VLDL, your IDL, your chylomicron particles, the other atherogenic particles, and all of these are like vehicles. So if you want to measure the total vehicles, that's what I call ApoB.
Oh, atherogenic
Means creating plaque in your artery.
right, the ability, the likelihood that it will promote like a clot, a cholesterol clot,
Uh,
right?
yeah.
So plaque is just a clot of cholesterol, right?
Yeah.
Constipated,
Sometimes attacked by immune
give
cells
it
and macrophages.
symptom. Yeah, yeah. Well, but it's a grouping of it's a clot made of all these different kinds of cells, right? But cholesterol is a big part of it, and then of course there's all those other cells you just mentioned. But atherogenic, just that's a big
Sorry.
word for a lot of people. That's okay.
Sorry,
Just
jargon.
asking. No, that's of course we default to that. So that's why you and I are here together, so we can say, can you explain that what that word is for somebody? So there's all these different kinds. So when you talk about, so just to sort of clarify what you said, in terms of that we are doing all this advanced lipid testing, we call it, in order to look at all these different kinds of particles that are floating in the blood, right? The different versions of cholesterol. It's not as standard as, it's not as simple as just what they call the concentration, right? So the LD, the panel your regular doctor does, it has a C next to it. And I think of that as, it's just like a concentration of the cholesterol. But then the P is the particles. And it turns out you can sort of break up all those cholesterols into all those different vehicles driving down the highway, as you said. And there are other ones that when you break it into its little pieces, right, or you break it out into all those kinds of vehicles, they all are a little different in how they promote creating plaque, right? And so which are the ones that are the ones we need to really look at, focus on? So if you were going to tell people, you should ask your doctor for this cholesterol test because it will tell you about your risk for making plaque.
Yeah, I would, right. So I would say that given the data we have at this point, you can ask for an ApoB as maybe the most accurate, a more accurate than an LDLC, more accurate than an LDLP even,
Right.
although that's still good. But an ApoB will give you a more of a summary
And
statistic.
LDL is your bad cholesterol, right? So LDL is the bad cholesterol. The HDL is the happy good cholesterol. Triglycerides are a little more related to blood sugar and exercise kind of thing. It's a little bit more in the sort of metabolic marker than it is as a straight cholesterol marker. And so we think of the HDL, which is the good one, and the LDL, which is the bad one. And Dr. Andrews was explaining all the different kinds of LDL that we have now that we can look at. But LDL has conventionally always been the bad cholesterol that everyone always looks at. Not even your total cholesterol so much anymore. It's really this LDL. And what we would put forth is that the research is really, really good for this thing called an ApoB, which correlates with your LDL, although there's a very, very small group of people where one's high and one's low, but usually they track together. And when you go on cholesterol lowering medication, it usually will also lower your ApoB. And so the good news is that if you end up doing something to lower your cholesterol, it should also lower your ApoB. But it's really important for somebody to be measuring your ApoB, because wherever that level is, that tells you one of your risk boxes, right? So if ApoB is over 100, you get a little check for a higher risk for heart disease, right?
Correct.
And
Correct.
so knowing what your ApoB is really important. And then I would also say what we talked about before about the lipoprotein little a, that one is also really important as well. That one doesn't track with your LDL, and that one doesn't track with taking cholesterol lowering medication.
Correct.
But that's another kind of cholesterol, but kind of, it's a lipid particle. But I love your story about the different trucks on the road. And so the carriers are really important. And those are that's what you refer to as the particles.
The
Yes?
ApoB, yeah, the
No, the
carrier.
ApoB. Oh, the
Yeah,
ApoB is the
yeah.
carrier.
So
Got it.
like I think of LPA, LP little a as like, oh, it's like a truck that's going along that's like dragging the tailpipe. Like it's just kind of like wrecking the artery as it goes. So the more of these like messed up trucks you have coming down, which unfortunately is just genetics, like you win the lottery or you didn't.
Right.
And like if you didn't, then we try PCSK9 inhibitors and we do everything else
Only
to
if you need
this.
it. Only if you need it. Like for me, I have a little high LPA. I have no other risk. That's the
No.
only thing. And it's medium. It's not really high. And I have low cholesterol because I happen to have a really good ApoE gene, which you'll talk about. So I don't need to do anything about it.
Yep.
And so this is how we like put we're creating sort of a picture.
Yeah.
And we have to fill in all the colors by numbers for everybody, right? For all the things we put together. So it's like family history and your cholesterol and your genetics, and then we put in all these lipid particles, and we try to determine if you're a high risk person and if we need to do anything, right, about
Yep.
it. And so,
Yeah.
and that's sort of the goal that we've been coming to. So I guess I'm deciding, do we need to talk about particles more? I think we're good. I think we could probably move on. Yeah. Okay, good. So that's your cholesterol. I think your take homes here are you should know what your ApoB is. You should know what your P little a, we call it, or lipoprotein little a. You should know what your obviously your basic cholesterol levels are. And there is something called and the particles that Dr. Andrews referred to, which we're not going to dig into so much here, but they're actually really helpful for us to understand, the bigger the size of your cholesterol particles, the better. The particle testing just tells us the size and shape of your cholesterol. It's like about the size of the particle. And the smaller the cholesterol, the smaller it is, and all the cholesterol particles can be big and small. So the good cholesterol could be big and small, and the bad cholesterol could be big and small. And my analogy is sort of, I tell people if you have 2 cups of cholesterol, or you have 2 cups of bad LDL cholesterol, and you look inside the cup, and in one cup there's cherries, big cherries, and in the other cup there's little blueberries. They're both 1 cup, right? But the particles and the sizes are different. And we can assess the size of the particles. And when they're little, they can sneak under the blood vessel, and they tend to be more atherogenic, to use your term. They tend to be more promoting making plaque. And so we want to increase the quality. And that's a quality issue, right? That's
Mhm.
not a straight number issue. Improving the quality of your cholesterol particles is something we work on. And that is good for lowering your risk of making plaque. And we'll talk more about how we do that as we get to the end. We're still working through our risk, right? So coming to moving more. So those are sort of the basic risk assessments, right? All the lipid stuff we got through, and family history and all that. Let's move into sort of the advanced risk assessment. So after we do
Yeah.
this sort of conventional lipid screening, what's next? And how does this help us guide our patients?
So some of the important labs that I'll often order for a patient that's curious about their individual risk, we will look at things like LPPLA2 activity, which is a big name for a lab that really means, is there active turnover of plaque in your arteries right now? And if that number's high, that gives us a sign that, you know what, we need to be a little more aggressive or assertive, I guess is the right word, with your management. And your myeloperoxidase level, which I mentioned before, that's another marker of inflammation that can be, show inflamed arteries. And then your high sensitivity
Why are inflamed arteries important?
inflammation in the artery will allow more of those leukocytes to bind and to integrate into the endothelial cells and to attract macrophages and create foam cells. Basically, it's going to make that cholesterol get under the artery and cause those zits that are going to pop. And that's what's going to cause heart
All
disease.
right. So inflammation in the arteries, inflammation or this thing called oxidative stress, which is just free radical damage to the arteries, right? Inflammation or oxidative stress in the arteries increases the risk. It's like it's like a blemish, right? It causes damage along the line of the arteries, which can cause things to stick to them. That's kind of my sort of simple sort of way that I like to explain it, because it increases your risk of making plaque in the arteries. It just
Yeah.
does. And there's all sorts of mechanisms that Dr. Andrews just detailed for you. We know how it happens, right? And so these measures, LP, PLA2, which you talked about, and myeloperoxidase levels, those reflect that there's some inflammation. It's some oxidative stress or inflammation in the arteries, right? Which is a problem, right?
Mhm.
And can increase your risk of making plaque.
Mhm.
As well as there are a couple of other ones. Share
Well,
maybe.
and so these other ones, like so the CRP, the C-reactive protein, the fibrinogen level, those are more generally markers of inflammation. But when we see those high, and it could be high because I don't know, you have an infection in your toe, or because you have a dental infection, or because got COVID a week ago, or there are a lot of reasons. But those are, acute phase reactive, the fibrinogen, and then the HSCRP, the C-reactive protein. They're just signals to us that like you need to look a little closer at this person. Like you're not done yet. There's
Right.
something going on.
So a good assessment for inflammation, oxidative stress, and those two very specific ones that are related to the blood vessel, right? Which is LPPLA2 and myeloperoxidase, right? I'm sort of re-summarizing. People can't hear this enough because these are tests that you're probably. So for those of you listening, these are tests you're probably unfamiliar with. So I think it's good to repeat them a
Good.
few times. Yeah.
Good. Thanks, Dr.
Okay. Yeah.
Yeah, and then in terms of metabolic health, an A1C, a hemoglobin A1C, the measure of the amount of glycated hemoglobin that is in your blood. And because hemoglobin turns over every 3 months, it's a measure of your 3-month blood glucose. It is now a diagnostic criteria for diabetes, type 2 or any
Mhm.
diabetes. So we look at that, but we also look at like your fasting insulin level, sometimes your adiponectin level, things that can give us a better sense of sometimes even glycated serum proteins like glycated albumin or things can give us a sense of metabolic health, which is an important, as we talked about, it gives us more data, fasting insulin, like a way to think about how sensitive are you to insulin.
Yeah. So we definitely need to do a good assessment of your metabolic health.
Yep. And then F2 isoprostane and oxidized LDL. So these are, as you said before, measures of oxidation, measures of oxidative stress, which is a precursor to inflammation and what will lead then to atherosclerosis. So it just allows us, like if you, I'm not throwing anyone under the bus, but if you go to a doctor, a primary care doctor, and they tell you that your cholesterol's fine, I also don't want to fearmonger, but there are people that still go on to have major adverse cardiovascular events. And maybe it's because some of these other markers were high.
Well, you're much nicer than me. I cannot believe that some people only get a lipid panel of 5 things and none of these things are tested. I just don't understand. And unless your cholesterol is so low that you're already in the target range for like a high risk person, I think it's malpractice to not have some kind of risk assessment done with some more tests than the basic 5 things: cholesterol, HDL, LDL, and 4 things, and triglycerides. Those are the 4 things people do. They'll get an A1C and glucose is part of a metabolic profile, but that's it. None of these oxidative stress markers are ever done. And so I love F2 isoprostane. So our panel, we use Boston Heart Labs a lot. So we send our advanced lipid testing. You can do it through Quest and LabCorp. You can get all these things through regular Quest and LabCorp, most of them. Oxidized LDL, maybe Quest does that now, but not Lab. That's maybe not. But F2 isoprostane, LPPLA2, myeloperoxidase, HSCRP, fibrinogen, insulin, A1C, all of those can be done through a conventional lab. You just need someone to order it. And the answer, and if any of those things are elevated, then we're really in good shape with functional medicine, right? Or integrated, because the goal then is, where's your inflammation coming from? How do we get your inflammation down? How do we reduce your oxidative stress? And those are classic great things that we do, which we're going to talk more about in a few minutes. Let's just move through the rest of let's get to that. I want to get to like our approach to helping, because assessing your level of oxidative stress and inflammation for heart disease prevention is extremely important. Okay.
Yeah, I
And
mean, I
so
agree.
we're like highlighting that here for you. And so and you can get this from your conventional doctor, and we do this for everybody. Okay. So you know what? We already talked about the oral microbiome. And I guess lastly, do you want to just the omega-3
Just
index?
that omega index, your omega-3 index is also something we can quantify. And so looking at the balance of omega-3 to 6 acids in your blood gives us a sense of your dietary intake, and also gives us a real lever for a way to lower your inflammation.
Right. And so unless it's contraindicated and somebody's on like blood thinners, or that's the main contraindication, I think, for putting someone on fish oil, really omega 3s, especially EPA, has been really well. There are certain things it doesn't do. And there's a concern in arrhythmias, right, about putting someone on high dose fish oil or fish oil. But other than that, going on fish oil is really good for cholesterol and for the quality of your particles. It helps increase HDL, the happy cholesterol, and in most people, genetically, some people are more prone to having it help them than others, but it will help make the small particles a little bigger, right? And so that's one of the reasons I really do like fish oil. So we'll measure, you can do an omega-3 index in the blood testing, and it will tell you where you are. And we know that a certain index level is good. And below that, a low omega-3 index, it puts you at increased risk for heart disease. It's like a well-known, and therefore you can get in a conventional test. So get an omega-3 index and supplement if you need to, or start eating some more fish or sardines or something that's high in good fat. So moving on, I'm trying to keep us in our hour that we promised everybody. So here's the next really interesting thing. So I think to summarize where we've been so far, this has been a great sort of laying out of all the risk factors that in your diagnoses or in your family, and then how to use blood work, right, to help you kind of get a sense of your risk for heart disease. At what point do we recommend that somebody gets imaging done? And so, and what is the imaging? And so before you answer that, I just want to I just want to state that the reason why the moment comes where it's time for someone to get imaging for me is more about, do you have plaque right now? Right? So everything else is sort of your risk and what we think it's happening, and your inflammation in your body and your cholesterol. But then the question can become, do you have existing plaque?
Yeah, like
Do you
yes or
have it
no.
in this moment?
Yeah,
Because that's going to help us know if how aggressive we need to be with lowering all your risks, right?
yep.
And so what say you to that?
Well, so I use the coronary artery calcium score, which is like a CT. It sounds like fancy, but you're not in the scanner for a long time. It's like a 2 second.
Right,
I
it's a
mean,
CT
so
scan,
fast.
right? It's a
It's a
CT
very
scan of
fast,
your
but a
heart.
very
Right.
fast CT scan with low radiation.
Right, it costs
Expensive,
$100, right? It's like out of pocket. It costs $100
affordable.
in most places, right?
Yeah, and it provides a quantitative score of the overall calcified plaque in your coronary arteries. That said, I think it is so. Couple
As a
caveats.
screening, maybe.
It is a screening test.
Right.
I think everybody over 40 like should consider it.
Yes.
That,
I've
and
had
I
one.
think,
I'm over 60 though, so I definitely should have one by now. But I encourage
yeah,
all my patients to get one. Yeah.
yeah. I think that if somebody is high risk and they come back with, like, based on our risk assessment, and they come back with a negative coronary artery calcium scan, I don't believe it. Like, I'm not
Okay, wait,
convinced.
time
That's
out.
it.
Don't get too
But
complicated yet. Let's just
okay.
finish talking about the calcium score, okay? So for those of
Well,
you listening, the calcium score is a good place to start. It has some drawbacks though. Okay. And so think of plaque in your artery, right? And a plaque could be like something, when you first get cut in your hand and the scab starts forming, and first it's sort of mushy. It's like soft and mushy, and it's like a soft scab. And over time, it becomes a scab and it's really hard, right? When you have this scab forming inside your blood vessels, it starts out, it's mushy. There's a mushy scab, but then there's the hardened scab. In your blood vessels, the calcium gets deposited once it's really hard. We call it an organized plaque, where it's hardened, it's organized, it's not soft anymore. There's no big soft spots, and then calcifications go in there. And so the calcium score only looks at calcified hardened plaque.
Right.
And as such, it does not at all look, or it's not able to measure and see when there's soft plaque.
Right.
And what Dr. Andrews said before about the rupturing of soft plaque, people are at risk for your heart attack risk is greater from soft plaque than this calcified plaque. Because once it's calcified and hard, it's not going to break as easy.
In fact, if you manage your heart, if you have a lot of risk factors and you had, whatever score on your coronary artery calcium scan, and you manage it well, and maybe you even get on a statin and you do all these things, your calcium score might go up significantly, and that might not be a bad thing. It might mean that a lot of your soft plaque is now calcified.
Is now getting calcified. And so
This is the problem, which is that it's not going to be accurate enough to follow people from one year to the next. It's not accurate enough to say that you don't have soft plaque.
well, I mean, right. It's not accurate. So this is where a cardiologist it comes in to really help you figure this out. Because in order to go to the next kind of imaging, which is we love and we want to tell you about, which is really an angiogram, where you have to do dye, and it looks at all your blood vessels in your heart and it shows all the plaque. In order to get that test, you actually will need a cardiologist to order it for you. And so the question really is, if you're a low risk person and you have a calcium score of 0, you're probably okay without, I mean, you are going to be okay without needing an angiogram. But there will be a small group, a small percentage of you that would be benefit from getting an angiogram. And so I tend to sort of push people in that direction when if they turn out to be like a high risk by other manners, right? So we go through our risk scoring, and they are a high risk person, which we'll talk about, high LPA, high cholesterol, high ApoB, but also family history, especially my family history people. And then you were going to talk about genetics next,
Well, I
briefly.
want to make one little sub point here, though, about the
Yeah.
angiogram. So there's like the invasive coronary angiogram where, somebody walks in, goes to the ER with chest pain, or maybe they've had chest pain for a long time. They get a catheter threaded up through their femoral artery.
We're not talking about that. It's actually just an
Yeah.
injection of dye, and then you
Well,
get a
that's what I just wanted to clarify.
yeah,
I don't want people,
it's like getting a calcium score, but you get injected with dye.
I just didn't want people to walk
Yeah.
away thinking you meant that
It was
everybody
that kind of
did
angiogram. Yeah, yeah,
the
yeah.
latter.
And
So,
I think we're getting out of, like, I don't want to get too, I just want people to know about this, and that there's
yeah,
different levels. We believe in continuing to push and keep going until we have a really, really accurate picture. And
yeah,
there are some people whose has a complicated story, complicated family history, complicated labs, and the calcium score doesn't really help as much as we hoped it would, where you might need to go to that next level, where we need to actually suggest that you get the next level imaging, which helps us really look at your vessels in your heart,
yep, yep,
right? And
yep,
so I think we can probably leave it at that, because I don't want to get into who needs it, who doesn't need it, because it's too complicated, which is why this is where I send someone to a cardiologist. I do all the labs that we talked about. And I'll often, if I deem someone to be a high risk person, then I recommend they go see a cardiologist, and we have a conversation about what the goals are to lower the risk,
yep.
right? And if there's further assessment needing to really image the blood vessels, if we think there could be soft plaque there, right? What do you think? I
Yeah.
mean, what else
No,
do you
I
think?
agree with you. I just would say that like as the technology gets so much better and the procedure is, this coronary CT angiogram that's
Yeah, do you want to talk about this
rapid.
theory, which is
We
this
can, we can
newest
keep
test?
going because we're almost out of time, but I do think that's clearly and heart flow is a similar one. They're using AI technology to really quantify which arteries affected and how blocked they are. And
See,
that
that's great.
is
And
a
then it
beautiful
becomes,
tool.
and if it becomes as simple as a calcium score, then everybody should get that.
Yeah, I think we're headed like slowly, we're headed towards that as maybe a primary screening tool.
Well, that's
So
amazing because
exciting.
and so I think that then we can leave what we can leave you all with is that we both believe very strongly that everybody should have some sort of imaging done to get an assessment of their current plaque. Do you have plaque right now? And if you have plaque, is it hard plaque, like you would see in the calcium score? Or is there soft plaque, which you would need some sort of an angiogram or these more advanced, newer tests that are out that are less invasive, and hopefully they will become easier to get and cheaper to get a really good picture of your coronary arteries. And in my view, that's what, that will be the gold standard someday, I hope as well. If you're a low risk person, the calcium score will probably be sufficient for now. And then to decide if you need to go to that next test, you would need to engage with a cardiologist. How's that?
All right.
Okay. So moving on then. So moving on, I think we're ready to sort of bring things together, accept that, and talk about treatment and how we sort of
Okay.
help make things better or help people lower their risk. Do you want to just briefly talk about genetics? Just a couple of the things we look at. I mean, I think
Yeah.
ApoE is
In the,
important in,
which one you said?
well, ApoE, which I
Yeah.
know.
Yeah. So in the interest of time, I think we had a lot more we could talk about here, but I will just say that genetics has become an important part of our toolkit for sure for thinking about cardiovascular risk. So the
Just
testing
list
we use,
them. Yeah.
yeah, the testing we use now, I mean, the data is just getting better and better in terms of we have, CEPT mutations, CDKN2A mutations. I mean, some of these, if you have two copies of CDKN2A, you have 100% increase in your cardiovascular disease risk, meaning like a twofold risk.
Wow.
Some of these genes are so,
CDKN. So CDKN2A.
it used to be like the 9p21, like in the Bale-Dunning
Oh, the
methylation.
9p21. I
Yeah,
just
yeah,
had someone test that
yeah.
one you can easily get from the
And so there's that, and then once we find these, if we find you have these genetic risks, if you have the ApoE4, if you have the KIP6, we can help determine kind of what would be the best. It really guides our management because we have data around each of these genes about, if we know if you have a CDKN2A, then you're going to need vitamin K2, and you're going to need. We can sort of think about what kind of things would help. Maybe some bergamot
Well, I
and
love
sedation.
bergamot. Okay, so and as we're moving into, and so there's genetics, right? And there's
Yep,
genetics related
yep.
to cholesterol. There's like the ApoE is the one that's been around a long time. But we were having this great discussion about bergamot before we hopped on this call, and it looks like bergamot's finding more like its sort of moment. I like that you talked about that it decreases LDL oxidation because I haven't had much I've used it in the past to help raise HDL. So I guess it's been looked at more about LDL oxidation now. So if you get an oxidized LDL or you want to lower, that would be an idea, right?
Yeah, it's also been shown in LDL in some studies that, none of these are large randomized controlled trials, but we're
Well,
using
that's the
the
thing.
trials that we have.
And by the way, people, you don't have to take bergamot. Bergamot is like English breakfast. It's an English breakfast, right? Or it's one
It's
of the black teas.
citrus bergamia. It's like
No, it's in a tea. It's in one of the teas.
oh, I don't know. Is it in the
Oh, it's a
tea?
black tea. So if you can drink a cup of black tea every day, if you Google it while I talk,
Oh, sure. There you
yeah,
go.
no, but I know because I had a patient who wanted to do it through tea and we looked it up and it's one of the black teas.
Yeah.
You'll find out,
Okay. Black tea.
or I can look it up. But bergamot's in black tea. Anyway, so yes, so we use genetics to help us stratify risk and and to understand your risk. So you can see as we're putting this all together, the how do we use your risk assessment? So these are all the things that we're going to put together that you should be thinking about, that you want to put together. If you have a positive family history, one of your parents had an event before they were, in the 50s or 60s, I would recommend that you seek out somebody who can help you really understand your risk better. The other people that I think it's really important to use, how to use your risk assessment, is what to do about your cholesterol. Because everybody comes in to see it, like everybody, and there was a period of time where everybody got put on a statin, right? If your cholesterol's over 200, you get put on a statin. And statins are great. I mean, statins actually solidify plaque, right? They pull the LDL, they take soft plaque and make them a little harder. They work great to lower cholesterol for people. There's a lot of wonderful things that people have benefited from that have needed to be on a statin. However, everyone doesn't need to be on a statin. And so knowing what your cholesterol target should be and to know whether you need to go on medication, we believe that this is a really important use of your risk assessment, right? So a high risk person, if the box, you have a whole bunch of boxes checked and you're a high risk person, then your cholesterol needs to be lower than someone who's a lower risk person, right? And so somebody with no risk factors, it's okay if their cholesterol is over 200, and it's probably okay, if their LDL is 110. But if you're a high risk person, your LDL has to be under 80, right? And so when somebody comes in with their high cholesterol, for me, I try to help them figure out, I help myself get clarity and help us both figure out what the target for their cholesterol should be. How high a risk are they? And therefore, what's our lipid target? It helps to work with Dr. Andrews and I both, tend to work with the same cardiologist that's around us. And, I always hear his voice in my ear, and it's really, about stratifying risk and then deciding on what the target should be. And for high risk people, the ApoB should be under 80 and the LDL should be under 80, but for a low risk person, you don't need to work that hard, right?
Right.
And so what do we do? So let's just wrap up by talking. Do you want to add anything to that before we wrap up?
I mean, that was perfect. Yeah.
Yeah,
We
okay,
could
good.
talk about some of our interventions if you want.
Yeah, so let's just talk about what tools we have for, or what's our approach then? And
Yeah.
so I want to start out by saying, before, Dr. Andrews also jumps into she has some great ideas for supplements and things, but, as well as everything that I'm going to talk about. But I want to start out by, at the end of the day, for those of you who have listened to me speak on many webinars before, I do these a lot. I, get on and sort of share my views with people. I'm very much an upstream, practitioner. I am an upstream doctor. I like to go as far upstream as I can, and meaning to the very roots of where the risk is coming from. And there's a lot of things that we can modify. And honestly, the lifestyle stuff can get you 80% of the way. And this is food, stress, and exercise, right? And so food, right? Very high in antioxidants. So how are you going to lower your heart disease risk with food? Antioxidants. We talked about inflammation, oxidative stress. You need more antioxidants. So if you have sparks, you need to be putting them out all day long, right? And then you can bring it in with food. We talked about heavy metals, and we didn't even talk about toxins in general. How do you lower toxins? You eat a detox loving diet, tons of vegetables, tons of fiber, tons of antioxidants, tons of polyphenols. All those things will help you mobilize and keep the toxins moving out. Tons of fiber. Fiber will stabilize your blood sugar. Fiber pulls cholesterol out of your body. It binds cholesterol and pulls it out. The cholesterol is released through your liver into your bile, and it gets reabsorbed unless you have enough fiber. So plant forward. I'm not advocating everyone needs to be vegan, but we do know that there's a whole lot of research of people who have sort of reopened their blood vessels by eating, a plant-based diet. And so veganism is the most extreme version, but we don't necessarily advocate that, except in the people who are in the worst, who are the highest, really want to do as much as they can with diet. But really a good Mediterranean kind of diet, we call it a cardiovascular, cardiometabolic diet, stabilize blood sugar, get the sugar out, keep your blood sugar even during the day, eat enough protein, but very plan forward. Lots, like I said, antioxidants, fiber. That's going to go a very long way for helping you with your cholesterol. Is there anything else you want to add about food?
I mean, beautiful. No.
Okay, good. Yeah.
Lovely.
The next piece is about stress. And I do want to add this in because it's so important. There's this whole other alternative sort of triggering pathway for increasing cholesterol production in your body. Cholesterol is used as the mothership for making cortisol, which is your stress hormone. The adrenals take cholesterol out of the blood and move it into the whole steroid pathway. It's the precursor for all the steroids, of which cortisol is like primary hormone. You don't have cortisol, you die, right? It's considered a primary hormone. And so if you have adrenal fatigue, which we won't debate that like language, but if your adrenals, if you have a lot of stress and you have chronic stress, acute stress, been through something traumatic, you've been burning the candle at both ends, there's going to be a lot of pressure in your system to make cortisol, right? And your adrenals will tell your liver, I need cortisol, I need cholesterol, make more cholesterol. So there is sort of a signaling kind of your body is all connected, right? So the endocrine system is connected to the cardiovascular, like it's all signaling and communication. And so there is this aspect about stress. And the other piece about stress is stress cortisol raises your blood sugar. And so cortisol is going to raise your blood sugar. And there are plenty of skinny diabetics who have bad plumbing, right? Because the sugar in the blood inflames the blood vessels. So getting the sugar out through food, but if you have high cortisol levels, you're going to be at risk of having high blood sugar just from the stress. And so all these things, see, I'm going upstream and looking at these modifiable factors. So helping your blood sugar, you need to be also looking at practicing relaxation, understanding what your cortisol is doing every day and how you might have a positive effect on that. And then the other big trifecta for the third one is going to be exercise. Do you want to talk about exercise a little?
Yeah, and I'll just backtrack to say that the other also the stress, the cortisol is going to tighten up the norepinephrine is going to tighten up those arteries. It's going to raise
It's
your
true.
blood pressure.
Thank
These
you.
blood pressure effects are then going to cause heart disease through other
I'll
mechanisms,
remind everybody that
fibrosis.
adrenaline is made in the adrenals, right?
Yep.
So that's the other part of the stress response is adrenaline, not just cortisol. So thank you for pointing that out because adrenaline will rev up your heart, right? It has a lot of effects on the heart, cardiovascular
Anyway,
system. Yes.
so I mean, moderate intensity exercise, 150 minutes a week is really like a standard recommendation at this point in cardiology for like just general health, just everyone, you know. But and sometimes for some patients we have to make more intense exercise prescriptions, you know, because it depends on somebody's individual goals and what they're looking for. But for health optimization, you know, how's your metabolic health? Do we need to incorporate resistance training? Probably. The answer is probably yes. But if you know, if we're working on metabolic health issues as well, it's critical. And as we age, that becomes so much harder to gain muscle. So if we're talking about health span, lifespan, that's one side of the exercise prescription. But just cardiovascular disease, we've got to get the aerobic exercise at least at 100, you know, at least at baseline. And let's say just say all of us are, you know, we're all we're all trying to practice what we preach here at the Blum Center. So all of us are working on these things, and we know it's not easy, or there's
Right.
no judgment. Like we know that life is hard, but like you know, I'm just telling you what like our goals are for ourselves and also for you. And so you know, we'll work together.
Yes, and I think that's a really good point and an important point about compassion, right? Compassion for ourselves, compassion for as we try to do these things, because lifestyle change is hard, which is why we have, like Melissa, our health coach, we have a full-time health coach here. And, everyone sees her, right? Because she helps with, you're trying to do it, but you can't quite get it done, right? So there's a lot of goals that everyone needs support, right? And so my whole goal for building Blum Center back when, a long time ago now, was to create a place where we can teach you how to do it, right? So it's one thing for us to tell you, this is what you need to do. And then the question is like how to help you do it, right? And so that's why there's coaching, we have cooking classes, and we also have a lot of support for food and blood sugar, which reminds me actually that for those of you listening, if you're interested in understanding your blood sugar, which is such an important part of all of this, we have something, our Vicky, our nutritionist, she's a functional diet, she's a dietitian nutritionist. We have a CGM program, and this is where you might use a continuous glucose monitor, right? And so we all did this here where we all I wore a Freestyle Libre for 2 weeks to just get a sense of what my blood sugar was doing, because I didn't really understand my food and how it was affecting my blood sugar. And so did you wear one also?
Yep.
Yeah.
Yep.
And so I learned so much from it. And so we developed a CGM program where you could just come and sign up with Vicky. And we prescribe the Freestyle Libre, and you can just meet with her every 2 weeks for, a bunch of sessions to really, and you can upload the data, into our computer, and it'll really help you work to get your blood sugar under control. And I think blood sugar is one of those upstream really important contributing factors for heart disease and for lipids and cholesterol making plaque and oxidative stress. And so the CGM, that's one really lifestyle. It's a biohack, right? That we can do to help support the changes, but having someone to help you, make some of these changes is really important. So as we finish up, do you want to say anything about supplements or medication or so it's upstream, right? And so supplements are like we believe in helping reduce inflammation, right? And antioxidants
Yep.
and
I think it's
cholesterol.
helpful. Yeah, we try to use things that have pleiotropic effects that are, beneficial for more, multiple things. So we'll get a flavor based on either somebody's genetics or their oxidized LDL or their, omega-3 index or their beta cytosterol. Like we didn't get into that, but like if we have these markers, these biomarkers or markers of inflammation in somebody, or a cortisol test, or things that give us a clue, like, oh, this might be a driver for this person, then we use targeted supplements that we know have effects for those things. So if we see an oxidized LDL, we have particular supplements we use. If we see a high blood pressure, like endothelial glycocalyx damage, like we have other supplements we use. So I don't want to go too far into the weeds with that because of the time, but I guess I'll just say that I look forward to, if anybody is interested in talking more about their personal risk, I'm happy to go
Right.
into.
And so wrapping up, I want to say a couple things. First of all, anyone here is welcome to come in and see Jane, Dr. Andrews. This is sort of her baby. It's just a passion, I would say, a passion for you as well as brain health, right? And anti-age and all these things. But Dr. Andrews is really taking the lead on creating a very comprehensive, even though we all do it in our practice, but this is a particular passion of yours, which is why we're here. So just reach out to us at Blum Center and you can schedule a consult. There were a bunch of Q&As that came in, and I just want to say a whole bunch of you. So when we send out the link to this webinar, what we'll do, Jane, I think we should send a list of those tests because everyone's asking, can you spell the test? Can you
Oh,
spell
okay.
what it is? And people there's a lot of questions about that. So everyone who's listening, when we send out the recording part of that email, we'll just send a bullet of the tests that we talked about. Okay.
Sure.
And
Sure.
so and so that was it. Somebody asked about the apolipoprotein B, and somebody asked about the link to the recording, yes. And so the list of tests, LPP, right? Yeah, LPPLA2. So I think we're just going to write them down. Most of these questions were all of that. What about a CTA with contrast? Is that more conclusive about cardiac risk? I think that's what we were talking about. Yes.
Coronary CT
That question.
angiogram.
Yeah,
Yeah,
that's the
that is with contrast.
angiogram.
And
Are
it's
these
very
tests
useful.
right? And are these tests covered by insurance? The answer is yes, with the right coding. You should be
If,
able to go ahead.
yeah. Well, I think, right. It depends on the right coding. Like
Right.
if somebody's got chest pain, for sure. If somebody, like we have the in-betweens are, we just have to figure out.
Yep. And so the inflammation tests for the arteries, you're going to see all of these tests. We're going to write them all down and they're going to go out into the email. Yes, yes, yes. We talked about the CTA with contrast and insurance. We really hope that they would be. I think we do a pretty good job of getting them covered. And so that's fine. We're done with that. And the last two questions, can you talk about small LDLP? And I'm only going to say one quick thing about that, which is that we talked about the particles. That's just one of the particle cholesterols. And the smallest one, the smallest of the bad cholesterol particles, I would say that that's the one that is the most worrisome that we look at. So that's the worst one. But interestingly, and I hear the cardiologist we've talked to in my ear saying that that can sometimes be driven by insulin resistance. And so if you have a high small LDLP, this is where we said there's a connection and a relationship between blood sugar. And so that's where blood sugar issues might be pushing a little bit there. So I'll leave that as my answer. And any issue with your HDL being high, there have been some studies about that. Do you want to leave that as our final thing to answer? Or there have been some concerns about that the HDL can be too high.
Yeah,
So do you know?
I don't have much more to add, just to say
Yeah,
that we used to think that it was always just good, but the HDL cycling through the liver is actually much more complex than LDL even. And so understanding kind of how the LDL gets cycled to HDL and the production of HDL, I don't think it's as clear cut as we used to think.
right. I wouldn't worry if you have high HDL. I think it's just something that we look at, but people who have a lot of other bad, not optimal markers, and then they have a good HDL that think that's going to be their saving grace, it's not necessarily so. And I would just leave it at that. I
Yeah.
think if everything else is good and that's good, and so it's just not as automatically fixes everything like maybe originally thought. So I think I would leave it at that. Okay, well, we answered all the questions you posted. I know a few of you might have sent a few things in. I'm sorry if we didn't get to those, but it was great being with you all today. You will get this recording. Come and see us if anybody needs any coaching support, getting these things done, changing your diet, CGM, and if you want Jane to be your Dr. Andrews to be your quarterback for all this, we work as a quarterback, right? So everything, if you know you're at risk and you're concerned and you want someone who really, really knows how to look under the hood and do a good assessment for you, then come see us. Okay, anything else you want to add before you want to say goodbye or?
No, it was a pleasure. It was a pleasure.
All
Here
right,
soon.
good.
All right.
We'll see you all soon.
Take care.